Well, hello and welcome to the 27th Degree with Chris and Nancy. So today we'll be discussing eye health with Dr. Nikolas Raufi. Before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And as always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review. And of course, 5-star reviews are always greatly appreciated. So maybe we can just start by hearing a little bit about yourself.
Yeah, absolutely. So my name's Nikolas Raufi, like you said, and might I say thank you so much for reaching out to me, Nancy. This is really a great thing that we get to do here.
Very welcome. We were very excited.
I think eyes are even confusing to people who are in the medical field and don't do eyes, and maybe some of that is all of our abbreviations. But it's nice to be able to go through some of these things. So I'm originally from Barrington, Rhode Island, one of 4 children, and I currently practice as an ophthalmologist in Johnston, Rhode Island. I am married to an optometrist, and so this is just eye conversations in my house. That's it, right?
That must be really interesting dinner conversation.
Yeah, really, really boring for our dog. Yeah. Actually, our dog's name is Maddox, and that is an ophthalmology tool used for double vision. So we're really, really, dad puns or ophthalmology puns around, right? And I love podcasts. I started listening to your podcast.
Great.
I do a lot of driving, and so I'm eager to learn about things and just love what I do. Yeah.
Nice.
Excellent. Maybe you can just tell the audience a little bit about the difference between an ophthalmologist and an optometrist, because I bet that's a question some people
all the time. Yeah. And so when it comes to the big difference is ophthalmologists are surgically trained and treat surgical and laser procedures. An optometrist, on the other hand, does not do those things. However, everything else is very equal. And I make that specification because I feel like sometimes patients need to understand that optometrists are capable and excellent at treating all eye conditions, barring surgery and laser procedures, depending on the state. So
that's a really clear way to define it, because I have to think when I think, okay, optometrist.
Yeah.
Yeah. Do they do injections in the eye?
Optometrists?
Yes.
Optometrists do not.
Okay.
Ophthalmologists do.
Yes. Okay. So no procedures in that manner.
That's correct.
But everything else is.
It's the same. Yeah. And so someone who doesn't need surgery can still see an ophthalmologist. Someone who needs surgery can see an optometrist, but for part of their care, that's non-surgical.
Right. Okay, that's great. That's good to know. I've gone to both, and I've never required a procedure. It's pretty much been the same experience for me.
Yeah, it depends more on the person. Right. Yeah.
Right.
So now, what are some just general guidelines to make sure you're keeping your eyes healthy?
I think keeping your eyes healthy. Number one, if you're over the age of 50, the guidelines stipulate that really one should have an exam once a year, and so having an eye exam once a year is helpful for screening. In addition, it's just keep your body healthy. So of course, good nutrition. I always talk to patients, they always ask me, should I eat carrots? And I say, well, I mean, carrots are good, but the carrots, they're not all they chalked up to be. You get a lot of vitamins and minerals from other, foods. And so eating a healthy diet is really important. And we're going to talk about, I think, some eye conditions like macular degeneration, where that is very important.
We will.
So other than that, exercise, of course. And I think wearing sunglasses is beneficial and important. I think it just helps with aging of the eye and to slow that down a bit. Wearing your glasses, if you need them, is healthy and important. But a lot of patients ask me, if I don't wear my glasses, is it going to hurt my eyes? No, you just won't be able to see, So,
Okay.
Yeah.
Okay, that's great to know.
Now, what are the most common things you treat in your practice?
So for me, the most common surgical procedure that I treat is cataracts. And cataract surgery may be the most common surgery in the world. I think in the U.S. alone, there's somewhere north of 10,000 surgeries a day for cataract surgery. Yeah. So that answer applies for most eye care professionals. Other than that, I do a lot of glaucoma care, and that is glaucoma care with drops, lasers, or surgery. Macular degeneration, of course, glasses. I mean, these are everyone, glasses are very common, and they're very trendy these days. May I say, Chris?
Yeah, you like those.
You look dashing. Yeah.
Hello.
I'm just kidding. He was closer, so.
It's all right. Wait till I get those blue contact lenses.
There you go.
So now, going back to talk about the cataracts, what is a cataract exactly?
So we're all born with a lens in the eye, and the lens is responsible for focusing the light and the images we're seeing on our retina. And when we're young, that lens is very movable.
Yeah,
and
mine doesn't move anymore.
yours is when you're old. That's what I'm just kidding.
It's true.
As
Yours
we
doesn't
gain
move
wisdom.
anymore, does it?
For years.
Yeah.
No, as we gain wisdom in our
Yeah.
years, then we gain wrinkles and cataracts.
Right.
But the cataract or the lens normally focuses those images. And as we get older, the lens not only opacifies to become cloudy, but it also gets more rigid as the
Okay.
proteins kind of cross-link themselves. And so that causes cataracts. But before that, it causes presbyopia. Presbyopia being the this at the dinner table,
Oh.
Yes,
as
yeah.
you're.
I have presbyopia.
Yes,
Yes, you definitely.
that's right. That's in the 40s and 50s, and then cataracts really come after that.
Oh my gosh.
It's
So,
a natural go okay process.
oh.
Yeah.
Is any of this like hereditary?
There are certain types of cataracts that can be. The vast majority are not, and
Yeah.
they're just natural aging processes.
And the hereditary ones, those are the ones you see in really younger people,
Correct.
here and there, right?
Absolutely, yeah. There are types of cataracts that babies get that they need to have treated early. But yeah, younger people, absolutely. There's other types of cataracts that are affected more by medical, systemic issues.
Right.
Things like diabetes. Anyone who's getting radiation this is not describing just an X-ray. Someone who needs real radiation.
Like radiation
treatments.
therapy for a malignancy or
Absolutely,
something of
yeah.
that
They can
nature.
get types of cataracts. Trauma is a very, fortunately, uncommon cause of cataracts, but it's on the list there. Yeah.
So is it preventable?
Cataracts, as of yet, no.
Yeah.
That is the billion-dollar question. So,
Not really.
there's a lot of technology or a lot of companies trying to find the elixir drop
Sure.
that will prevent them, but to be, at least the way I look at it right now, to cure cataracts is to cure aging.
Yeah.
You have to be able to, and other than surgery, there's really no way around that for cataracts.
I mean, it's incredibly common. I had 2 patients came in today for, pre-op clearances, which there's really not a lot involved.
Yeah.
Because it's a really safe procedure.
Oh yeah.
But to today, and probably every week I have a couple people that come in for evaluation for cataracts.
I think last year we ran my numbers. I did about 1,400 cataracts.
Oh
Oh my
goodness.
gosh.
And that's just in 1 year. Yeah. So there's a lot.
Right.
Oh my gosh.
It's really, I very rarely have a patient that has issues.
Really?
I
People do
really
really
haven't
well.
seen much of that either with my
Yeah.
patients. in
How
my
do you know
primary
if you're
care practice.
developing cataracts?
So the main thing to know or to pay attention to would be my vision's blurry and my glasses aren't working. That's the first question,
Oh.
the first and easiest thing that you can answer for yourself at home. However, what then you need to do is see a doctor, because the reason is there's other reasons why your
Sure.
vision can be blurry, and it's easy to chalk it up to glasses or cataracts, but it could be dryness on the front of the eye.
Yep.
It could be macular degeneration, even glaucoma, a lot of other, things as well. So see an eye doctor.
How about at night vision? That must be affected a
Yes.
lot. I've
It's-
had patients tell
yeah.
me driving, headlights coming at
It's
them.
the
are a
most
big issue.
common complaint is, we talk about blurry vision and we talk about glare, glare, halo,
glare.
starbursts. What happens is cataracts, because of the cross-linking between the proteins in the lens, the light that comes in, it should be straight on, it bifurcates. And that's what causes so much night driving difficulty for
Yeah.
patients. And that's a huge advantage of cataract surgery, because we can put in an artificial lens that the light hits perfectly. It doesn't
Right.
do that anymore.
Now, someone has, let's say they're very nearsighted or they have an astigmatism. Do you fix that with the lens?
It's a great question. So this is where my favorite part of cataract surgery is how I can cater it to my patients specifically. And we all have different eyes and different amounts of nearsighted, farsighted, or astigmatisms. And so what we can do is we can reshape the cornea, similar to what LASIK does, but not quite the same. We can do that during cataract surgery. That's laser-assisted cataract surgery. It's one thing that I actually specialize in. That will reshape the front of the cornea to reduce or remove astigmatism. The lens itself will reduce the rest of the prescription.
Okay.
And so sometimes you need a lens that treats more astigmatism. That's a toric lens. And some people actually try to reverse what the malady Nancy was, worrying about before, which is that losing that nearsightedness.
Right.
So there are multifocal lenses that can use their technology to give a patient good distance, intermediate, and near vision, all kind of at the same time and seamlessly. So the technology of ophthalmology is really amazing, the way it's moved forward in the last few decades.
Is it like a progressive lens with your glasses, that type of an issue?
It is, but it doesn't work the same way. In other
Okay.
words, it's not like the top is distance and the bottom is near. The lens actually works by having like rings, and the rings have apodized diffraction patterns that bend light in certain ways to extend the depth of focus of the eye. And so what it's doing is it's splitting light. And that light splitting helps you see at multiple focal lengths.
When you
wild.
develop
It's wild. It really is.
That's
It is. Yeah, I mean, I think it's exciting. At least.
when you develop one cataract, do you usually have both eyes affected?
Usually you do. They don't have to be symmetric, but it's very common to have a cataract. I do get patients a lot that come in and they say, oh, I have a cataract here. We have to fix that one. And I said, well, you have one in the other eye too. And they're like, I do. And it's very common. We have two arms. Everything is pretty symmetric in the body, barring trauma or radiation or something, right? But yeah, generally it's both eyes.
Now you do the surgery separately though, right?
Yes.
One eye first and
Yes,
then the other eye.
that's something that like Kaiser Permanente in
Yes.
California has begun doing bilateral surgery at the same time.
Really?
And so there have been very, very large studies out of that institution and other parts of the world where they have done both eyes on the same day. And what happens is all of the instruments, all of the tools, viscoelastics, little jellies, anything that's used is kept on a separate table for each eye.
Okay.
So everything is treated like a completely separate surgery. You re-sterilize everything. However, the vast majority of practitioners in the United States do not do this, and I don't do it yet. There may come a day, but not yet.
Why?
Because if something were to go wrong, you really don't want it going wrong in both eyes. And it does give a chance to let the first eye heal for a couple of weeks before you do the second eye.
Isn't it like so common that you kind of do it in your sleep and like you
I'm not
like,
falling asleep during surgery.
No, but it's just like one of these things where like the outcome, like 98% of the time there's a great outcome. And
Yeah.
It's just like,
Yeah, it's so the surgery does have it's high risk, high reward, right? So 99+% of patients do extremely well,
okay.
as long as their expectations are set, right? It's important to kind of go through what they should expect. And then, there is that 1% where there's something different, right? And usually we can see that before surgery. We see something that is unique about that eye.
Okay.
I definitely do the surgery so often that it becomes robotic in a way, and you want that. I love it because I can perfect more and more and more the same thing over and over and over again, and that's fun for me because it gives you that outcome you're describing where patients come in the day after surgery and they're like, wow, like that was great.
I think that's the thing that is so amazing about this surgery is the patients they don't realize how much vision they've lost. And then they have it done and they're just amazed because it's gradual over many years. And then all of a sudden, within a very short period of time, they can see better.
Yeah, it's to get back with the patient the hypothetical patient I was discussing before. They'll want surgery in one eye, and I'm like, well, you have one in this eye, so let's book it, and we'll see. You can always cancel it. And invariably, what happens is we get this eye done, and they say, oh my God, now I realize my good eye is now my bad eye, and so they want it done.
Right.
So you're totally right.
Yeah.
So does the night driving improve instantly and stuff too? Or
Yeah.
are they still sensitive?
Yeah, hard to say if it's instant, but generally that's improved. I do joke with patients because my patients, the LEDs on cars are so bright now
Oh my
that
God, it's
some of that I just
horrible.
can't help. I'm sorry, I can't put
Right.
sunglasses in your eyes, so
Hey, maybe that's the
I
next
know.
thing. I don't know.
There
We
you
should
go.
think about that.
Well, that's great. And are there any contraindications or reasons not to do this surgery? Are there patients that could not have it done because of a potential medical issue or whatnot?
there really aren't many. There are ocular contraindications, for example, people who have inflammatory conditions that really we should wait until the inflammation is calm before doing surgery because that's pro-inflammatory. In terms of medical conditions and systemic conditions, it really guides more the location of your surgery instead. So a lot of my surgery is done at an ambulatory surgery center where we don't put patients to sleep. However, some people may need to have general anesthesia if it's a child, or some people I've done patients who are hundreds, 100 years old, and that is not uncommon, and it depends more on the patient.
Sure.
A lot of people can do that, but there are some who really just feel too ill or
Right.
to have lack of mobility or something where they really can't undergo cataract surgery.
Okay, that's great to know. And if they're on blood thinners, they can still have it, which is a nice
and they
thing.
don't even need to stop them.
Right, that's wonderful too. I think patients are always amazed at that.
Yeah.
They can remain on those
It comes up every single day. Today I had 2 that asked me. They're like, should I stop my Eliquis? I said, nope. Keep it going.
That's cool. That's really nice.
Maybe we should move on to another. Although you may have a question. You look like you were ready to ask something.
She's
I
eager.
was reading your mind. I was going to say, so the other thing that you said that you treat a lot of is glaucoma. Can you talk to us a little bit about
Yeah.
My mind. That's amazing. You did.
Because
I was just going to go
like
to that.
osmosis.
You guys should do a show together. I think, you know?
Right?
It really seems like this is working. Glaucoma is extremely common also, and it affects many adults, especially in the United States, and children also. There's many types of glaucoma, but generally speaking, it's a condition where the nerve in the eye develops damage secondary to pressure in the eye.
Okay.
And that pressure normally is higher than the average pressure, but it doesn't have to be. People can have a sensitive nerve and therefore have normal pressure but still get glaucoma. And alternatively, people can have high pressure and not develop any nerve damage. But it's all about that nerve damage, and it's about an ophthalmologist or optometrist looking at that nerve and seeing if there's change over time, thinning, or evidence of damage.
So do you feel that? Do you feel any of that pain from the pressure?
It's a great question. Generally, no. The general types of glaucoma, the pressure doesn't go up quickly enough to develop this type of pain or pressure to the eyes. Okay. And what instead happens is, unbeknownst to patients, you develop kind of a loss of peripheral vision slowly. And we're talking over decades. And so because it's so slow, the brain doesn't realize, hey, I'm not actually seeing anything over here. And that's why using automated testing or manual testing, where we test a patient's ability to see in their periphery, is really important. There is one type of glaucoma that is very rare called narrow angle acute angle glaucoma.
I was going to ask you about that to describe the difference.
Yeah, and we, when we're in medical school, it's one of the big ones. We learn, we learn about that, and we learn about open angle glaucoma. But the narrow angle glaucoma that causes this acute rise in pressure is very uncommon. Yeah. That type of glaucoma allows your pressure to increase within hours. Oh. And that's very painful. Okay. And it's also very blinding. And so it'll be very difficult. I don't want to encourage the listeners to your show to associate every headache they have with this, because it's almost always not. But it is associated with boring headache that causes nausea and vomiting. Okay. That's how much pain there is. And that you do need to seek, at least medical attention.
Would the eye be red? Would they have other?
Eye would be red, vision would be blurry, tearing sometimes. Okay. So going to an emergency department, especially one where there are eye professionals, would be a very good idea.
Okay. So is glaucoma like an aging disease too? Is that in my future?
Yeah, all of us. Yeah. So it's a little bit aging. There's a little bit of genetics that goes into it. So definitely it's a hereditary. If you have family history of glaucoma, it's something where you want to be a little more cognizant about seeing your eye professional about it. But it's not inevitable for everyone for aging. Not in the way that cataract is. Not everyone's going to get that.
Is it stoppable? Like, so you're doing my exam and you're like, oh, shoot, you have glaucoma. Yeah. Like, what?
No, I let you leave. That's it. No. So the nice thing about glaucoma is it's one of the many parts of ophthalmology where technology has really, revolutionized how things are treated. So we generally start in glaucoma by providing eye drops. And eye drops are a simple thing that someone can do at home. Okay. Compliance can sometimes be difficult, right? Reminding yourself to use your drops, something that you don't feel. Remember, we said glaucoma, the most types, you don't really know what's going on, right? And so it's hard to be cognizant about, using that drops in much the same way that I'm sure like your blood pressure patients don't always use their blood pressure medication because they don't realize their blood pressure is
they forget it. It happens all the time.
It's easy. It happens to me. So for some of these patients, what I choose to do and what a lot of other practitioners do is we can provide laser treatments that can help reduce the need for those drops. And so those laser treatments are not painful. What they do, yeah, exactly. First question, right? They're not painful. What they do is they help open the outflow of the eye. So if you think of glaucoma as a problem where the drain of the sink is becoming a little narrow and maybe getting full of some, it needs Drano essentially, right? Okay. So what we can do is a laser procedure that helps clean that area up. That, again, doesn't hurt. And that can give you 1 or 2 years or more of not needing to start drops. And the best part is that procedure is repeatable. The new thing that really excites me that I currently do is something called MIGS. MIGS is minimally invasive glaucoma surgery. Oh. So it's a way of treating someone's glaucoma concurrently with cataract surgery you're there anyway. You may as well try to treat it,
Right.
but doing it in a minimal way, in a way that it affects their glaucoma vastly. But these stents that we use are so small, it's like a grain of sand is what they look like. And I have a little one that I show my patients sometimes. They're tiny. And so being able to do minimally invasive surgery like that, it just changes the outcomes for patients and it makes things a lot easier for them. So that's really exciting, new technology.
That's awesome.
Yeah.
So it's a progressive disease?
Glaucoma is, yeah.
Okay.
Yeah. Once you lose what you lose, you don't get that back,
Oh.
unfortunately. Yeah.
So I'm hearing like from this and the prior conversation on cataracts that it's super important to see your eye doctor on a regular basis.
Yes. Yeah. And again, you're hoping for a boring exam.
Right.
Yeah.
I mean, most adults should probably have an evaluation yearly, I'm
Yes.
thinking.
Yeah. Yeah. The AAO recommends every 2 years after age 40, every year after age 50.
Okay.
Yeah. And then, anyone
You're
younger
in
than
the
that.
after age category, so just so you know.
I'm like 10 months ahead of you.
But you are older. I'm just making that comment.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
All right. Well, that's great. That's a great summary on glaucoma and
Yeah.
cataracts. And I guess the other thing that we see a lot of is macular degeneration.
Yeah. Yeah. Macular degeneration is a very unfortunate condition. And it also affects many adults usually. It comes with age. It's very familial as well.
Okay.
That's something that our patients would notice, a blurring in vision that, again, wasn't helped by glasses, and then they get cataract surgery and that didn't really do it, So it's very important for us as practitioners to obtain imaging of the retina of the eye. So to back up a little bit here,
Yeah.
what macular degeneration is, what is the macula? The macula is the center of our vision. It's about the center. It's whatever's clear in your vision, whatever you're looking at, everything that's clear there, that is the macula. And over time, that macula, or I should say the retina itself, is the most metabolically active tissue in the entire human body. All right.
Okay.
So it is churning through energy and creating trash. And what can happen over time is that trash can build up and it can cause deterioration of the overlying retina.
Okay.
That does split into two categories: dry macular degeneration and wet. Now, dry macular degeneration is just what I just described, deterioration of the retina. The wet version is when that deterioration allows blood vessels to flow into that area, and then those blood vessels are not built very well, so they leak, and then you get fluid. So that's why it's called wet.
Okay.
They both have different treatments. They both are obvious for the practitioner, who's looking at the eyes. But it's an important thing, again, to get a yearly exam to check for those maladies.
Is one worse than the other?
So I think people generally think wet is worse. And by people, I mean more the patients. And the reason is the treatment for wet macular degeneration is injections. That's the most common treatment. Those injections are actually much less painful than you would think. I know we always come back to pain because an injection to the eye is a scary thing. But I think if you ask most patients who get those injections, if it's a bothersome experience, they would say, no, it's totally fine because we numb the eye, right? Now, wet macular degeneration, though, has that treatment. It has, you can do injections and stave off wet macular degeneration. So dry macular degeneration is, I guess we're saying, the better version, but it doesn't have a treatment.
Okay.
So that's a problem itself. So when you develop enough dry macular degeneration, even if you don't have wet, it causes vision loss centrally, and that vision loss is irreversible. So they're both very unfortunate conditions, and our hope is that the patient and we as a society do whatever we can to kind of stave it off as much as possible.
I have had some patients who've had injections for, wet macular degeneration, and some of them have actually done quite well.
Yeah.
And they feel their vision has improved.
Yeah. Mm-hmm.
So what happens, like if someone has a combination of all this stuff, like
You mean all three conditions, for example? Happens all the time.
Yeah.
Our exam for
Question.
ophthalmology does it generally contains 5 or 6 diagnoses, all just pertaining to the eyes. And so what really happens is we treat it stepwise. We really have to break it down and compartmentalize it for our patients
Right.
so that they understand what each condition is, how we're treating each condition, and most importantly, what is each condition contributing to their vision, right? Because the most common thing, especially when you're going to do surgery for cataracts, for example, is educating our patients that, hey, you also have macular degeneration. Your cataract surgery is not going to do anything about that. Right. And so the logical next question is, well, how much of my vision will I be able to regain? It's a very hard question to sometimes answer, but we can always give an
Sure.
idea of it.
Yeah.
So as someone that has like diabetes and hypertension, so you're, well, I'm sure you're always hyper alert, but now these types of patients are going to present a higher risk.
Yeah.
So are their exams different?
No, we try to stay very stepwise with our exams on purpose. Just like everything else in medicine, you get regimental, right? And by doing that, you don't forget things. And so
Gotcha.
we look at the same parts of the eyes and we look for discrepancies. So for diabetes, for example, we're looking for small little pinpoint bleeds that occur when blood vessels don't work very well in diabetes. We look for fluid that is kind of building up, like swelling in the retina that happens in diabetes. For high blood pressure, I've had patients where, I look at them, I say, do you have high blood pressure? And, generally it's in the chart, so I kind of know anyway, but their blood vessels are very tortuous. And they say, oh my God, how did you know that? It's because the eye is the window to the soul, right? So that's very cliche, but it has some truth to it. There's a lot of parts of the body that we can tell about, just by looking at the eyes. The optic nerve, which is, we talked about with glaucoma, it's brain. That's brain tissue. That's our way of seeing, is there pressure in the brain right now? Is there an issue with tumors, with, malignancy, anything? So. Yeah.
Dr. Raufi, most of these procedures, what's done in your office and what has to be booked through like a surgery center?
So all of my lasers are done at the surgery center because the surgery center has the laser there. All of my surgeries, of course, are also there. What I do in the office is small, minor procedures, little bumps that need to be removed, or people get the styes and things like that on the lids, right? That we can definitely do in the office. The rest of the exam, all the imaging, all the preoperative assessments, we get these beautiful widescreen photos of the eyes, even without dilation now. All of that occurs in the office.
Oh.
Injections you do right in the office.
Injections we do in the office too. Yeah.
Can we do anything at home for a sty if we get a sty?
I love that you're asking that question, because I have so many patients that come in with them, and this would be broadcast to the world now. So basically, a sty is just a pimple. It's a pimple that is really annoying and can sometimes be very painful.
Yeah.
The most important thing is hot compresses. Yes. And patients do come in with, saying, I've been using this towel, I get it wet and I, warm it up.
Right.
It's not enough.
Oh.
There are masks that are sold online and at the store where you stick them in the microwave and they stay hot for a full 10 minutes. They are vastly superior. And what you're doing in that case is you're applying heat to allow a pimple to basically express itself, Beyond that, artificial tears. Sometimes we provide an antibiotic, but as you can probably glean from this, it's a pimple. You don't really need an antibiotic, but sometimes it helps a little bit,
So now that we're talking about some of these common things that common maladies, let's go through a few of these, because this comes up all the time. Conjunctivitis.
Yes.
Oh.
I see that all the time, and everyone wants an antibiotic for it, but it's not really necessary.
It's almost never necessary to have an antibiotic for
Really?
it.
That surprises me.
It's generally not bacterial. So
right. And to be honest, most conjunctivitis is not even viral. Most conjunctivitis is irritation on the eye from dry eye. So using anything like artificial tears that's usually what is needed. But it's just an irritation. So that could be a piece of a leaf got in your eye and you didn't know about it. That could be that, yes, your child has a cold and you developed a viral infection, does not need antibiotics.
So do you still have to stay out of work for 24 hours?
Not necessarily. I do think daycares are very particular about pink eye, of course.
Right.
But at work, there's at least from what I know, most jobs don't require you to stay out. No, just wash your hands frequently and give it some time and they'll go away, but they're annoying.
It must have the amount of conjunctivitis must have gone down with COVID with everyone
Yeah, it
washing
probably
their
did.
hands.
Oh, absolutely.
I
yeah.
didn't think about that, but I don't see it as much as I
Yeah.
used to because
Yeah, people have better hand hygiene.
That's
although
right.
everyone's gotten away from masks and washing their hands now, so we're going to see a resurgence of it, I'm sure.
Is
It's
that what
coming
you're
back
predicting?
with a, with a
Awesome.
vengeance.
Yeah.
Excellent.
So, all right, here's another annoying thing that people get: floaters.
Floaters.
Oh,
I
yeah.
love this
Can we
question.
talk about that?
Yeah, and I actually enjoy talking about floaters. I've built an analogy, and you guys let me know if it's actually good, because maybe I've been saying this to patients and it's not. But I think of the eye like this room, okay? And the wallpaper on your room is the retina, okay? That should stay there against the side of the room. And then what happens is the eye needs to be filled with something, so it's filled with a jelly. That jelly is inflated into a very clear balloon that expands all the way to the walls of the room, okay? And that is the vitreous of the eye. As we get older, that balloon that we're describing, it actually deflates at some point. And what happens is that edge of the balloon, which was nice and tight, right? Like saran wrap, you can see right through it. What it does is it kind of folds over itself a little bit. That's a floater. So what you're seeing is basically part of the vitreous jelly that is an opacity, that is totally natural, but that has separated from the wall of the eye. Developing that floater is not a bad thing. It's annoying. They stay there forever. They don't really go away until they get out of the center of your vision, but they're there forever. The important thing for your listeners to listen to and understand about floaters is they're not inherently dangerous, but they can lead to something dangerous. And that's why I mentioned the retina at the
Retinal
beginning.
detachment.
Yeah, exactly. So if that balloon deflates and it's pulling off, pulling itself off the side of the eye, we don't want it to take the wallpaper with it. So if it pulls hard enough, it can tug on that wallpaper. So far, not a problem. But tugging on the wallpaper causes the flashes that a lot of times accompany floaters for patients. A lot of times they go hand in hand. And then, I was just going to say, and then if it pulls hard enough, it can tear the retina, and that can cause a retinal detachment. But that would cause thousands of floaters and a loss of vision, like a curtain.
So what happens, like, if someone has cataract surgery and then they experience floaters? What's happening in that scenario?
So the most common thing is that they actually had floaters before, and then now with their clear vision, they're seeing them. And I usually tell patients, I didn't put your floaters there. They were there. I do make a very strict point of saying that most of the time. But of course, what can also happen is, every surgery has its risks. And cataract surgery, there's a lot of fluid, a lot of movement, and we don't do anything in the back of the eye where the vitreous is. But the front of the eye has movement going on, and that can precipitate retinal tears. It's very, very rare. You can't quote me, but I am on air. So it's about, I think, a 1 in 800 chance. Okay. So far less than 1%, but still possible.
So it sounds like we take. I'm sorry. Did you have any weird other weird
I'm used
stuff
to you
you
just
want to
taking
talk
control and asking all the questions. Go for it, Nancy.
So it sounds like we take care of a lot of things down here. So there's no need really to go to Boston unless you have some extreme weird case.
Yeah, I think that's exactly right. Almost every eye condition can be treated here in Fall River, Providence, any other place in Rhode Island. Now, what Boston provides one subject that they provide would be certain types of malignancy. Those are so rare that you're really only going to find 1 or 2 people in an area that do it. Yeah. And so that is something that regardless would be screened and caught by a general practitioner like myself and then sent to Boston. But other than that and other, unless you have some very strange parasitic infection from the Amazonian, then you really don't need to have an eye exam up there. They're great. Of course, they're all wonderful doctors. They're wonderful doctors everywhere. But yeah, patients don't need to be going all the way up there.
Yeah, most of the patients who I've had who've gone up to Mass Eye and Ear or whatnot, they've had like melanoma of the eye or something of that nature, which isn't really, I guess, treated down here as much.
Yeah, that's right.
Yeah, so...
Do you do a lot of LASIK surgery too? So
LASIK surgery, I'm trained to do LASIK. I'm actually just building that practice right now, and so that should be up and running. There's financial barriers to LASIK surgery as someone who does the surgery, but yeah.
I'm so glad you mentioned finances. So when you have cataracts and glaucoma and macular degeneration, is most of the treatments covered under insurance?
Yeah. Most of these treatments are medically covered. The things that are not are, I suppose they're considered cosmetic, even though cosmetic has a wrong connotation to it. It's not just about looks, right? So the way I lump it is refractive surgery is not covered by your insurance. And therefore, what that means is laser-assisted cataract surgery, not covered. Specialty lenses beyond the standard lens are not covered. And of course, you just mentioned LASIK is not covered. So these are types of things that are not covered. There's also other more actual cosmetic procedures like Botox treatment, types of cosmetic facial oculoplastic surgeries that are not covered by insurance.
Okay. Just going off that cosmetic piece, more and more people now are getting cosmetic treatments to their face to retain their youth. Does that ever interfere with eye health, like Botox or eyelashes, or?
It can. It's very rare. It's very rare. Of course, we've all, in the MD range, we've all done our residencies, and as optometrists have also. So we see, the 1 in 10,000, situation where something does go poorly, but it's extremely rare. Yeah.
Nice. Now, can you share a story with us about a patient that had a great outcome that you're like?
I absolutely can. Although I'm going to read some stuff for you because I actually, the listeners are like, oh my God, he knew about this. But yeah, I did keep some words from a patient that I thought was really, really nice for me. It's a very rewarding profession overall. But I'm going to read this out loud verbatim. Okay.
That's great.
Yeah.
So basically, this patient, lives in Vermont, and of course, before surgery, had profound glare, like we described before, and really, vision was not being helped by his glasses, and so he came to me, hoping for what we call toric lenses to correct his astigmatism, and of course, that comes with the cataract surgery. So we did laser-assisted surgery with toric lenses for him, but he wrote me this letter afterwards. He said, "Dr. Raufi, I wasn't as fulsome in your praise as I meant to be on our last visit. There aren't many positive gifts the medical profession can give a 78-year-old surcease from dribbling, a less crotchety knee or hip, perhaps. But what you've done, even in the normal course of the day in your profession, is in fact a profound gift. And I appreciate it deeply. New eyes. Would that the body and brain were able to keep up. The essayist and naturalist Annie Dillard once postulated what a person who had been blind from birth would see if she were suddenly and dramatically given sight. She would see, looking around her garden, not a tree as we understand it, but a tree of lights, the sun refracted and splintered in 1,000 inexplicable and magical shards throughout the leaves. Both my wife and I have taught courses from that starting point, the awakened eye. In my case, our front porch in Vermont, I used to see a row of our fields, and then a further range of pastures in the distance, the green mountains, which were all a gray blur. Now, my God, the mountains are a brilliant blue swatch in the evening. You cut into my eyes, an intimacy so profound that one could hardly have predicted it. And now you've given me back the brilliant carpeted landscape of a late autumn in Vermont." So it makes me kind of teary with it a little bit, only because I know him so well, It was.
Is he a writer or a poet? I was amazed that he used the word fulsome, and then it just got better from there.
Yeah, he's and then surcease. I had to look up surcease, by the way. So we've had a little bit of a correspondence since then.
Sure.
And he's an incredibly nice person. He did give me permission, obviously, to read this.
That's amazing.
What was, if you don't mind me asking, what was wrong? Like, what did you do with him? What kind of treatment?
Cataract surgery. This is what I call boring cataract surgery.
Right.
And that's amazing.
But you have a dramatic effect on lives, obviously.
Right. And although, with him, we did a toric lens. That is not covered by insurance, and people still get a dramatic effect like this without a toric lens. But his ability to describe his vision after surgery is not, or his ability is unique, but the effect he's had is not unique. The vibrancy that comes with these new lenses is really brilliant.
Wow, that's an amazing, amazing
Yeah.
review or discussion.
That's like
it's
the
nice.
best review I think I've ever read.
I don't know if he is a professional writer, but he should be a professional writer.
Right?
Yeah.
You
I mean,
definitely should.
I'll let him know next time I talk to him.
Yeah, that's phenomenal.
Yeah.
You know, it's so true though. He hits right at the heart of everything. Like vision, it's just the essence of it.
Yeah.
It's hard not to.
It's hard to
be
function
able to
without.
see.
I
I mean, I
remember.
lose my glasses, and I'm like,
Yeah, you can't see anything, right?
A mess.
I think NPR did they did an interview in like New York City once where they just, Gallup poll type thing. They
Right.
interviewed a bunch of people. What are you most afraid of in terms of your health?
Yes.
Number one was cancer.
Of course.
And this was I think this was a few decades ago, but the number two was vision.
Really?
Was blindness, yeah.
Interesting.
And I think it makes sense. We are so intimately connected with our vision that to lose it is,
You're right. Exactly.
So, Dr. Raufi, what's coming up that's new and exciting in like research, and what kind of things have you read about that excite you? And you're like, oh, and then you have dinner conversations with your wife
know.
about.
There's a few things that come to mind already. So there's two big categories here: medical treatment and surgical treatment, right?
Yeah.
So in terms of medical treatment, one of the big categories that excites me a lot now is myopia treatment. So myopia, meaning nearsightedness, is incredibly common, and especially in like China, for example. Okay, and so that increases the need for glasses for people around the world. That's fine because glasses fix that, but wouldn't it be nice if we could just avoid it entirely? And so there's a lot of treatments and a lot of technology going toward preventing myopia, and that doesn't just mean, although it's true, get your kids outside. They can't be doing this all day. And that, homework is great, but iPad, close work, it really does influence the degree of myopia.
Yeah.
But beyond what we can control in that sense, the eye care provider can now, if it's the right patient, they can provide eye drops that help kind of slow down the progression, types of contact lenses now that slow down progression of these things. It's all very new. It's budding, but it's profoundly important because it's literally going to affect billions of people, when it gets there. But surgically, as you heard, my passions are cataract surgery and glaucoma. With cataract surgery, the golden light that is going to hit us is going to be a lens that accommodates, that is able to move when we put it in the eye. Right now, we're currently putting a lens that is a piece of plastic. It's rigid, right? And so we limit the view and the vision that a patient can have. But if you have a lens in the eye that mimics the one we had when we were 10 years old, that could move and everything,
Sure.
then that's really restoring vision completely.
Yeah,
And
that's
that is
incredible.
really cool.
So before we close, is there one message you'd like to give our audience?
I get an eye exam. That's, I think, the most unfortunate thing that I see sometimes is a patient who comes in 5 to 10 years after they should have had their cataract surgery. And it was because they were putting it off.
Right.
And then the surgery just gets more and more difficult. That's still doable. I can do that. But, we want to see these patients, and we want to make sure that people are healthy, and if I see someone and they have totally normal eyes, great. We get to go a whole year without needing an exam.
Right.
But you need to have the exam to know that, so
Okay,
that's
great.
important.
So, how do people get in touch with you, and do they need a referral?
So they do not need a referral. It kind of depends on the insurance. Some insurances, I suppose, do require referrals from your primary care doctor, for example, but most do not. The best way to get in touch with me is in my Johnston office. So that's in Johnston, Rhode Island. I know a lot of your listeners are in Fall River, but 195 is a great drive, so unless it's traffic. But the address there is 1524 Atwood Ave,
nice.
Suite 240. It's in the AtMed building, so there's a lot of other medical offices in that same building. And the phone number there is 401-272-2110. And then, of course, we have a website, johnstoneye.com, JOHNSTON, I.com. So you'll see my picture on there, although they all know what I look like now. So
That's right.
Yeah. That's great.
Well, Dr. Raufi, I want to really thank you for being on the show. This was actually really, really
I loved
interesting, and we
Yes.
learned a lot, and I'm
Yes.
sure our audience did too. And
I had fun too. Thanks.
yeah, I know this was a great discussion. So thank you very much, and I want to thank all of our listeners for listening to the show. And if you'd like to become a sponsor, because we do exist through our sponsors, please contact us at 774-319-4230. Special thanks to Ron Gamache for our intro music. The the PC Institute for producing our show, and Bay Coast Bank, which is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Thanks again. And everyone out there, thank you for watching our show, and we'll be back again soon. Take care.